I just want to introduce our speaker for today, Dr. Glenn Aylward. Dr. Aylward is Professor Emeritus of Pediatrics and Psychiatry at Southern Illinois University School of Medicine. And he served as Chief of the Division of Developmental and Behavioral Pediatrics and Psychology for many years. He is a fellow in 6 divisions of the American Psychological Association and is board certified in clinical psychology and clinical child and adolescent psychology. He has served on numerous committees and executive boards with APA, the Society for Developmental and Behavioral Pediatrics, and the American Academy for Cerebral Palsy and Developmental Medicine. Dr. Aylward is a past president of the Society of Pediatric Psychology, also known as Division 54 of APA, and the Society for Developmental and Behavioral Pediatrics. He also served on the board of directors of the American Academy for Cerebral Palsy and Developmental Medicine and has been associate editor of the Journal of Developmental and Behavioral Pediatrics since 2003. Dr. Aylward has authored more than 100 peer-reviewed papers, chapters, abstracts and reviews, including the Bayley-4 and the Bayley-4 screening test. And we're delighted to have him here today to share his expertise and knowledge. And without further ado, I will pass you on to Dr. Aylward. One other thing, sorry, I will be monitoring the chat box while Dr. Aylward is presenting. If you do have any questions, please pop them in there. We will have some time for questions at the end as well, so I urge you to put your questions in there. And on that note, I will pass you on to Dr. Aylward.
Good morning. I'm delighted to be here once again. And the underlying issue today is to explain why we did what we did, or is there a method behind the madness? As you can see, I have a picture of Nancy Bailey there, and she's kind of looking over my shoulder. I am very indebted to her for setting the solid foundation for infant and toddler developmental assessment. I also put the pictures there to dispel a rumor that had been circulating at Pearson and San Antonio that I was Nancy Bailey's grandson. I'm not, although we do look similar with the glasses. So with that, let me start. Well, let me start again here. Okay, I have a disclosure. And I am the author of the Bayley-4, as you are aware, and the Bayley-4 screening test. Here is the agenda. I will try to stick to this as closely as possible. Here are the objectives of the webinar, and hopefully we will hit all of these adequately as well. Okay, so let me reiterate what I think components of developmental assessment include. The first is administration of structured items. These would include such things as problem solving, fine motor skills such as block building or copying, use of peg boards, use of form boards, things of that nature. The second component of developmental assessment involves direct observation of behaviors and milestones. I think this is critical, and we put a lot of emphasis on this in the Bayley-4. We look at such things as the child's method of walking or gait, the use of arms and hands, how well the child pays attention, the reaction to the caregiver. And basically, what we are doing here is getting additional information. So William Osler stated way back in time that 90% of the diagnosis is made by history and observation, which is true today as well. The active participation of caregiver and use of Caregiver Report, I think, is a critical issue for developmental assessment as well. There are 56 caregiver items. This has 2 basic purposes. The first is the parent or caregiver does not know what to expect during developmental testing, and this tends to put them at ease. It also enhances buy-in as they understand the assessment. They also probably are more successful in soliciting cooperation from the child. And if the caregiver is calm, the child is going to be calm. So this is one of the things that the individuals who like naturalistic assessment really emphasize, and I think it is a legitimate component of any developmental assessment. The history is important as well. It separates the clinician from the technician. Certain conditions have specific areas that need to be monitored. For example, a child who is extremely preterm with a high-level intraventricular hemorrhage would have problems in gross motor and fine motor skills in particular. The child who comes from a low SES environment may have language issues. Similarly, a child with Down syndrome is going to have more difficulty with abstract language, and so the scores in the beginning of testing are going to be higher than scores administered at a later age. So one of the first tasks that we were faced with was to maintain the basic quality of the Bayley scales. I wanted to be consistent with the original nature and purpose that Nancy Bayley had outlined. She subscribed to no one particular theory, but it was influenced significantly by Gazelle. Now, as you see, we switched to the 5-scale format when the Bayley-4 was introduced, and we stayed with that for the Bayley-4. Bayley and Bayley-2 also had an MDI and PDI, and that wasn't a clear separation. Those were broad cuts, and some items could go either way. By having the 5-scale format, we also had a better idea of the child's strengths and weaknesses. And this was going to help in terms of intervention planning. So rather than reinvent the wheel and drive everyone over the edge, I basically tried to make the wheel roll better, which I think was a pretty clever metaphor there. Another goal was to maintain validity, because we want to have a test that assesses development and do so in a reliable and valid manner. Now, the test per se is not valid or invalid, but rather the scores and how you interpret the scores make the difference. Now, there are 3 primary ways to determine validity, and the first 2 are things that I'd like to expand upon briefly, and that is compare the test to extant measures and compare the normative group data to specified clinical groups to get diagnostic utility. Some of you may recall seeing this slide on previous webinars, but I think it's an important one because it shows the evolution of the Bayley and gives evidence as to why we are where we are now. The Bayley scales were originated in 1969, and then the Bayley-2 came out in 1993. Now, when the Bayley, and both of them had the MDI-PDI format, when the Bayley was supplanted by the Bayley-2, the MDI decreased by 12 points, and the PDI decreased by 7 points. This was attributed to the Flynn effect. However, the Flynn effect in a recent meta-analysis was indicated to increase 3.4 points in the cognitive realm per decade, while the motor increased by 2.49 per decade. So nobody really questions the difference, attributing it all to, as I said, the Flynn effect. Then came the Bayley-3 in 2006, and the cognitive, when compared to the MDI, increased by 6 to 10 points depending on the study. The motor increased, and the correlations were higher actually between the MDI and language than they were with the MDI and cognitive abilities. And there are various reasons why this might have occurred. And possible reasons for discrepancies include we had different normative samples. The demographics varied. The SES, education, ethnicity, geography. Things changed between 1993 and 2006. Inclusion of 10% at-risk children. I must admit I was worried about that quite a bit as well. However, when we reanalyzed the data, including the children who were at risk versus those who were not, we found a 1-point difference, suggesting that this wasn't the major reason for the discrepancy. I think one of the more likely reasons was the restricted item sets and differences in the basal and discontinued rules. The original Bayley was 10 positive scores for basal and 10 missed scores or zeros for the ceiling, for the cognitive function. For the motor function, it was 6 and 6. When you went to the Bayley-4, however, it had age-based item sets. And basically, the cognitive had 5 or more passes in the item set and 3 or more fails, and that was it for the ceiling. So it was truncated. The motor was 4 and 2. Then we come back to the Bayley-3, and it was 3 passes and 5 fails for both. And similarly, the Bayley-4 is that way. The Flynn effect was attributable to 8 different variables in children, and the only one that seems to be valid is a change in nutrition over time. You may have also been aware of this comparison, but basically what we had were 184 children. The mean age was 19.2 months. The days between the counterbalanced administration was 10.3. And as you can see, there's very little difference between the Bayley-3 and Bayley-4 scores. So, and one thing you need to keep in mind here also is that the Bayley-3 was done on paper and pencil, whereas the Bayley-4 was done on Q Global. So there is comparison between the paper and pencil administration and the Q Global or digital administration. And we compared to other extant tests, and the Bayley-4 cognitive was a scale score of 9.7 or a composite score of 99, and the WIPC-4 full-scale IQ was 103. And you can see the language is comparable, and the cognitive is comparable as well. There were 104 children involved. Mean age was 36.6 months, and it was 8.1 days mean difference between administrations. And when we looked at the Bayley-4 and the Peabody developmental motor scales too, you can see that the total motor scales were identical. The mean age here was 18.6 months. There were 100 children in this comparison, and the average was 10.9 days between testings. And one other thing with validity is when we looked at clinical groups. Now, as you can see here, we had there are 410 clinical cases, and children had Down syndrome, autism spectrum disorder, language delay, specific language impairment, developmental delay, motor impairment, moderate to late preterm, very and extremely preterm, and prenatal drug and alcohol exposure. In every case, the children in the clinical groups did more poorly than their matched controls. Now, I want to shift to the neuroenvironmental synthesis model because this is a model that has affected the selection of items in the Bayley-4. And actually, this rationale is explained in more detail in an upcoming book, the Bayley-4 Guide for Clinical Use and Interpretation. It's published by Elsevier Academic Press, and it should be available in early 2020. This model is based on evolving concepts and new data regarding brain function and related developmental acquisitions. The major premise is that external biologic and environmental influences work in combination to have an impact on the internal brain development of the child. Enhanced synaptic connections in neural circuits will yield developmental gains and increase complexity of behavior that can be observed or assessed with the Bayley-4. Within this is plasticity, epigenetics, and recovery of function from damage or disruption. There's also the concept of canalized behaviors. These are pre-wired behaviors that are less affected by adversity. And this is in contrast to higher order cognitive functions, which are more complex and have geographically distant brain circuits. And the white matter pathways are more susceptible to insult and disruption. The problem that we are faced with is that these simple canalized behaviors, such as bringing one's hands to one's mouth, are heavily loaded in early developmental tests, and they don't predict later dysfunction. So what are the components of the neuroenvironmental synthesis model? Well, plasticity involves underlying cell assemblies. There are what are called experience-independent cell assemblies, which are groupings of cells that fire together. And the synchrony is important because those that do not fire in synchrony basically are subject to apoptosis or they are eliminated. This is a prenatal issue, so we don't deal with that very much. What we do deal with are experience-expectant synapses. These are pre-wired, but they need input from the environment to become active or to become primed. For example, prior to 6 months, children can discriminate the phonemes of all languages. However, from 6 to 10 months, they are better at discriminating language that he or she is exposed to. Deaf children babble, but because there's no input they stop. Hubel and Wiesel won the Nobel Prize with kittens utilizing an experimental approach to experience expectant synapses by basically covering kittens' eyes immediately upon birth. And when they uncovered the eyes after a period of time, the animals were functionally blind, and when they sacrificed the animals, the occipital lobes showed a wasting of circuits and a paucity of interconnections. The experience-dependent synapses are modified by an environment, and they have learning involved, and memory is also involved there. These are postnatal, and the circuits continue to develop over time. Now, epigenetics is a hot topic. I don't want to get into it too deeply here, but basically the activity of the DNA is changed, or how the gene is expressed. For example, smoking has a negative impact on glucocorticoid receptors, and that is going to have a negative effect on brain growth. Rett syndrome is another example of epigenetics, whereby the MECP2 gene is methylated or toned down so it doesn't produce proteins. I'll leave it at that, but just realize that the environment, once again, can change the genetic expression of the child. And finally, we have disruption, insult, and reorganization. Disruption is found with preterm infants who are born, and then basically there's temporal and architectural changes in their brains because of exposure to environmental stimuli that they shouldn't be exposed to, let's say 26 weeks. Insult is damage, and you get that with asphyxia, hypoxic ischemic encephalopathy, and so on. And then you have what's called reorganization. Reorganization isn't necessarily always positive. In other words, some cell assemblies that should have died off will remain. Similarly, let's say there is a left hemispheric damage, and the right hemisphere assumes some of the load. Well, unfortunately, by doing that, the right hemisphere does not necessarily perform at the level that it's supposed to if it had not been exposed to that additional load. So there are new connections and deletions throughout. The interesting thing is the higher order complex cognitive processes are more intricate in terms of interconnections. They are longer distance interconnections, and they evolve over time while extending white matter pathways. One of the questions that we're faced with is how do we detect these from earlier behaviors? Then we have the environment. In proximal, which is close in, would involve such things as the mother-child interaction, stimulation in the home, the effect of siblings. The status factors would be the neighborhood, socioeconomic status, poverty, and so on. With respect to the environment, you have physical exposure of a negative type oftentimes, such as tobacco, BPA, lead, or other toxicants, such as drugs. You have experiences that could be negative. The NICU, the NICU, experiences overwhelm the central nervous system of a very premature infant with visual, auditory, nociceptive, which means pain, and proprioceptive input. Social transactions can affect brain development, such as early adversity, low SES, as I mentioned before, lack of stimulation, and the overall allostatic load. And there are omissions and commissions, exposure or lack of exposure. For example, an omission would be the infant who is born at 24 weeks who misses out on intrauterine nutrition provided by the mom. Alcohol is a commission because of the negative impact on brain development. One other thing that is mentioned in the Bayley manual is what I call experiential bias. And that means that the testing should not measure stuff or tasks or skills that the child does in their everyday environment, because that's going to put some children at a distinct advantage and others at a distinct disadvantage. So back to focusing on the test, the main purpose is to detect developmental delays. So what I wanted to do is refine assessment at the low end via more easy items, giving partial credit, and making sure that the item gradients were not such that a small change in a raw score is going to produce a major change in a scaled score. This apparently or reportedly also has major impact on age equivalence. So in actuality, I'm more interested in the floors versus the ceiling or high-end items. I'm more interested in the children 1 and 2 standard deviations below the mean, because most children are referred for the Bayley testing because of concerns regarding their development. It is not to get into an Ivy League preschool feeder system. So I wanted to include items that measured acquired skills, learning and problem solving, and things of that nature, because these are what are predictive of later cognitive abilities. To show you an item grading issue, there's one developmental test that will go unnamed, remain anonymous, but at 5 months, one raw score point is a scale score of 74. 2 raw score points give a standard score of 90. That is a big jump. Similarly with the memory scale between 9 and 12, you can see the percentiles have increased dramatically. There was an IQ test that was out that has been supplanted by a more recent version. But if you had a raw score of 0, you would get a scale score, a standard score of 72. In other words, as long as you showed up, you would get a score of 72. Actually, I guess if you didn't show up, you'd still get a score of 72. So in order to achieve this refined gradient, I elected to use a Polytomous Scoring approach of a 0, 1, 2. There's an obvious difference between the child who receives a 0, where the skill is totally absent, and the child who receives a score of 2, where the child is proficient. However, there is also a difference between the 0 and a score of 1, because this means that the skill is emerging and probably is reflecting just a mild delay, whereas the 0 could be a delay or a deficit. So the 0, 1, 2 allows for gradations, particularly at the lower end. let me give you an example. One is jumps both feet. It is gross motor item 48 on the Bayley-4. And a 0 response would be the child doesn't jump, tries to maybe flex their legs, but both feet are glued to the floor. The scale of 1, the score of 1 rather, means that the child might jump with one foot up, leaving the surface, but the other one providing support. Whereas a score of 2 would mean that the child is able to jump with both feet leaving the surface simultaneously. Let me give you an example of a neuromaturation item. Asymmetric tonic neck posture not present. That is a sensing posture. And basically, cortical maturation inhibits lower brain centers. This is gross motor item 12. And what you're doing there is scoring 2, meaning it doesn't show up at all. 1 is it shows up sometimes. And 0 is it shows up frequently. So once again, you have to look at the 0, 1, 2 in a different fashion. Now, another goal was to include caregivers in the evaluation process. This gets back to the authentic assessments versus these standardized norm reference assessments, because it was criticized that the SNRAs were artificial. So what we did is we looked at what items could we use parent report in. And language and motor function are 2 of the areas that children refuse frequently. Similarly, the items representational play, imaginative play, which are cognitive items 50 and 59 on the Bayley, were difficult to administer, yet they yielded rich information. And parents probably have a better perspective on whether this occurs or not than we would in a 60-minute, 90-minute, whatever it is, administration of the test. And what we found was that there were no differences between caregiver report and actual observation or administration items. So these were deemed to be valid and reliable. There are 56 items, as I had indicated, and this minimizes missing scores due to refusals. It reduces testing time, and it gives you insight into more typical behaviors that the child may demonstrate. Another goal was to reduce testing time. And there's a balance here that needs to be struck between trying to be all-inclusive versus being more parsimonious. Previous versions of the Bayley were criticized because they took too long. Large numbers of items increase reliability, but validity is questioned because of fatigue, disinterest, irritability, and so on. Our goal is to reduce the time by 30 to 40%. And this was done by combining items, reducing redundancy. And for example, why have the child build all these different structures with blocks if they can do one and the other ones are highly interrelated or highly correlated? You're just basically doing the same thing over again. And the Bayley-4 View Global, I think, was the key to reducing the administration time. These are the administration times from the Bayley-4 Global. From 16 days to 6 months, 30 days, 34 minutes. From 7 months to 12 months, 41 minutes. To give you a comparison, the Bayley-4 took 90 minutes at 12 months. And you can see the others. And we kind of topped out at about 69 minutes for the older children, which still isn't bad. And some of these times were affected by the fact that there were breaks, that the even though criteria were met, sometimes we would still keep going just to collect more normative data and so on. I wanted to expand the content coverage because our ability to assess children evolved from the neurologic function to motor function, which is gross motor function like head control, things of that nature, to sensory motor, which is reaching behavior, to cognitive behaviors. And this depends on the child's age. Another way to look at this is we assess basic skills, and this would be something like reaching or grasping. These can be combined into a function, such as reaching, grasping, and bringing an object to the mouth, and then it could evolve into an integrated functional unit where the child would overcome a barrier to obtain an object that is then brought to the mouth. This would be a good example of that is the clear plastic box cognitive item 35. This involves integration and coordination of discrete functions. There's problem solving, there's motor modulation, there's planning, there's object permanency, there's working memory. And this is the basis for later intelligence. And it relies on, as I said, integrated neural networks. Also, I wanted to look at how the upper brain centers, more specifically the cortex, inhibits lower brain centers, such as the brainstem and cerebellum, vis-a-vis Emile Tisson's work. And that's why I included the asymmetric tonic neck posturing, the palmar grasp, hands fisted, because these behaviors persist. There is some disruption in terms of the upper brain centers inhibiting the lower brain centers. Another major thing that has come about is the finding that motor and cognitive tasks activate the same areas of brain. And this means that the dorsolateral prefrontal cortex is activated, as is the cerebellum. They crosstalk. These two areas of the brain interact particularly well if the cognitive task is difficult, if the task is novel, if there is a need for a rapid response, and if there is need for concentration. So this is assessed in the Bayley-4, and it also gives some credibility to the fact that there are motor deficits that are predictive of later cognitive function. So there are several suppositions that I want to close with. First is that behavioral and developmental acquisitions parallel brain development. You need the underlying capacity to demonstrate increasingly complex behaviors. Both begin with simple components and become more complex as the child ages. You can't do complex behaviors without basic brain circuitry. Our challenge is to determine what constitutes continuity and which behavioral and developmental components are indicative of the capability of more advanced function. And what happens here is that some apparently unrelated behaviors may have similar underlying circuits. The functional neuroimaging evidence suggests that motor and cognitive activities activate the same brain structures. The dorsolateral prefrontal cortex, the cerebellum, and the striatum, or caudate. And as I said before, they work together when the cognitive task is difficult, it's novel, response of a rapid nature is needed, or concentration is needed. Basically, these characteristics indicate that higher order executive functions are involved. And in children, there's a dramatic growth from 2 to 5 years in terms of executive function. And these early indicators of verbal working memory, visual working memory, processing speed, attention, inhibition, and cognitive flexibility. We measure these on the Bayley early on with habituation items, awareness of surrounding items, appreciation of object permanency, working memory for pictures, for words, numbers, and then later IQ and academic achievement and social emotional development are all dependent on these executive functions. Unfortunately, it is difficult to evaluate executive function in less than 4 years without overtaxing the child. So our challenge is how to identify more simple, lower-order indicators or precursors of these complex skills early on. And as I said, we included tasks that measure early indicators of these functions on the Bayley-4. Stated differently, with advancing development, more complex geographically distant circuits evolve. These develop later and are more susceptible to damage. They are built on basic, simple circuits. These circuits parallel the unfolding of more complex behaviors. It is difficult to determine continuity of specific functions because they are manifest in different behaviors in young children and are not easily parsed from each other. And I think a long-term task in developmental assessment is to identify what early precursors are of these more complex behaviors and functions and determine how disruption in these precursors may be manifest. And with that, I would be glad to take on any questions.
Wonderful. Thank you, Dr. Elwood. If people would like to type any questions into the chat box, I will ask them. I have a couple come through, so I'm just going to read out one to start with. If you've been using the Bayley-3, is it easy enough to move on to Bayley-4 and convert scores? So, for example, if using the Bayley-3, can we move forward with Bayley-4 and have comparable data?
Okay, first of all, there's two parts to the question. One is it easy to transition from the Bayley-3 to the Bayley-4? My answer would be yes. The next question is, are the scores comparable? I think they are, given the Bayley-3, Bayley-4 comparison of 184 children that we had shown early on. I think what happened is the Bayley-4 is doing more of a centering of scores, and it is kind of surprising that it is so similar to the Bayley-3 in terms of scores, given that we changed the scoring format. We had a whole different group of 1,700 children and so on. So I think what facilitated that was the 5-scale continuity between the two measures.
Excellent. Thank you very much. Okay, here's another one. With the Bayley-4, can individual parts be administered separate from the whole? So, for example, can the motor scales be administered separately? I could answer that one, but I'll pass it on to you first, and I might have a little bit to add on the end of that as well.
Well, I think that depends on the question at hand and the amount of time that you have to administer the test. If you're specifically interested in motor function, I would suggest you do both motor subscales. Both, I say, because there are some differences in performance on the two scales depending on the type of disability the child might have. Obviously, the whole test is desirable, but it isn't necessarily needed. In our follow-up clinic, we are going to have, at 3 years of age, a division of duties so that the speech-language therapist can do the language scales, we'll do the cognitive, and we can have the OT and PT do the motor. And I think that would be quite helpful.
Great, thank you. I was going to add something similar at the end, and I was also going to add that we do have the forms available, so the language and the cognitive language and motor forms are available separately in paper format as well. And we've created a motor kit, much like we had with Bayley-3. There was a motor kit, and there is a separate that has been. It is available as a standalone possibility or option as well, but as Dr. Elwood said, it is preferable to use the whole kit, but those other options are there because we know of those scenarios where people do want to administer in that way. Okay, another question. I'm worried about the caregiver report. Some of our parents over-report what a child can do, and they're overly optimistic. And some of our parents are lower functioning and have difficulty reporting what their child can do. Did you run into this at all?
We ran into that to some degree, but it was not as major as I thought it was going to be. I think by giving them the metric, the cognitive metric of 75% of the time, or almost all the time, less than 75%, which is some of the time occasionally, and zero response will be the child can't do it. I think we are eliminating some of the bias. There's also a way to check that out by if the examiner suspects that the parent or caregiver is inflating the child's performance, you can ask some leading questions on things that you know the child can't do to see what the parent or caregiver responds or if they report. If that is the case, then you may need to just administer the item.
Great, thank you. Okay, and here's another one. What is your recommendation as to how much time should elapse before a child is retested?
Well, it depends on the area of function. I would probably wait 3 months. Once again, this depends on the nature of the disability or the reason for retesting, such as eligibility and so on. There is, we found that even 10 to 14 days is adequate with younger children. They're not going to remember it, but with older children, you probably need to do that 3-month interval.
Okay, thank you very much. Okay, here's another one. Do your norms account for children from culturally and linguistically diverse backgrounds?
Well, the cultural and language backgrounds are tough because even if you're Hispanic, there are a lot of different countries and cultures that are Hispanic. What we did was we matched our population, the 1,700 children, to the 2017 census data, and that included maternal education, ethnicity, area of the country, socioeconomic status, etc. And we also looked at zip code, the average zip code earning amounts, and they were in line as well. So yes, you have to be careful if the child is speaking Spanish. I'm using that because that's a frequent question that is brought up. You have to be careful that the translation, you can use an interpreter, which we often do, but the interpreter needs to be told that they have to say exactly what the examiner is saying.
Great, thank you very much. Okay, here's one about the adaptive behaviour scale. The items on the adaptive behaviour scale are taken from the Vineland. Were they taken directly from the Vineland, or were they adapted in some way, such as wording or any new items?
No, they were taken directly from the Vineland.
Brilliant, thank you very much. Okay, let's have a look at another one. Is prematurity considered 36 or 37 weeks? And how long do you adjust for prematurity for?
Well, that's an interesting question. Actually, prematurity, late premature birth is 34 to 36 weeks. Do you adjust for prematurity? Yes. We said in the Bayley-4 manual that you adjust to 2 years of age. I analyzed the data in the format that Peter Anderson and others in Australia did, utilizing the Bayley norms. And this paper will be coming out in the Journal of Developmental and Behavioral Pediatrics. But basically, what we looked at were how would the child fare with the same raw score if they were 1 month older, 2 months older, 3 months older, and 4 months older, basically accounting for not correcting for prematurity. And what we found was that everybody needs correction to 2 years of age. In the cognitive realm, you needed correction at 3 years of age in those less than 20 or equal to 24 weeks. In motor and language function, it looks like correction for prematurity is necessary to 3 years of age, regardless of the actual gestational age of birth.
Brilliant, thank you very much. Okay, here's another one about growth scale values. Just asking if growth scale values are reported in the Bayley-4 and if you can use those for, obviously, to contribute towards for re-evaluation purposes.
Yes, growth scale values are reported in the Bayley-4. They are not given as much page space with the charts as in the Bayley-3, but I think the growth scale issue is helpful because it basically measures the child against himself or herself versus against peers, and it looks at small increments in performance that may not necessarily show up in standardized scores. So it's still there, but let me just say this, that it was not used nearly as much as we thought on the Bayley-3, and hence it's not given as much emphasis on the Bayley-4.
Great, thank you very much. And I think that's all the questions we have. We've got, if anybody wants to post in a last-minute question, then please do so. But while I'm just waiting and just see if anyone's got a last-minute question, I will remind people about the process for CEs again. So from Asha, the instructions are, for those who maybe missed this at the beginning of the session, you need to attend the entire session. You need to complete the attendance sheet if there's more than one person at your site. You need to complete the Asha participant form and the Asha evaluation form and return it to Darlene Davis. The address is on the screen, but it's also in the handouts, and you'll receive the handouts after the session. As we do need those back no later than October 10th. For APA and NASP and AOTA, slightly similar, a few differences. You do need to complete the evaluation form for the session, which again was included in your invite, and this needs to be sent back to Darlene Davis no later than October the 10th again. So I don't think we've got any last minute questions, so I just want to say a thank you to Dr. Elwood for a very, very informative session and sharing his expertise and wisdom on the Bayley-4. Dr. Elwood, do you have any last comments before we turn the session off?
No, just that if any of the attendees have any additional questions, please let you know or email me at gaylward@siumed.edu, and I'll be glad to answer the questions if I could.
Excellent, thank you. And just a correction, I think I said October 10th, I meant October 4th on the forms for CEs. So yes, thank you very much, and thank you, Dr. Elwood, for a great session. And
you're
bye-bye, everybody.
welcome.
Enjoy the rest of your day. Thank you. Bye-bye.
Have a good day.